So in Bay 1, Bed Space 1, we have Harry Bow. Harry Bow is...
Historically, our nursing handover has always taken place behind closed doors. Staff squeezed into a room and information was disseminated in a lengthy, unstructured, often chaotic and frequently confusing manner.
The cough has really been quite troublesome, and whenever he came in, his respirations were up at 66 and his oxygen levels, they were about 89. Oh, actually, this is not the right chart, hold on. Let's see. No, that's not it. Look, I probably left it there. Anyway, he's in an incubator and his oxygen levels are at 35%. Well, actually, they might be 28% now. You maybe need to just check it whenever you're out.
Oncoming nurses would take notes on pieces of paper as the outgoing nurses described symptoms and conditions of up to 12 patients at a time. Misinterpretation was common and significant information was omitted with alarming regularity. Handover was lengthy, and this meant that nurses were away from the floor for increasing amounts of time. Buzzers could be left unanswered, and there were frequent interruptions from phone calls, inquiries, parents looking for assistance, and medical staff requesting information.
Hi, does anybody know who's on with Katie? So she's due
Yes,
medicines.
Katie.
I'll be 2 more minutes.
Right.
Okay.
Sorry, Bob, we're not for long.
The oncoming nurses, conscious of the time, would be reluctant to ask questions or clarify information, and the outgoing nurses often left the ward feeling anxious and uneasy, with an overwhelming sense of what have I forgotten. By bringing the handover out of the office and to the bedside, we have implemented a process which has addressed many of these shortcomings and placed our children and their parents at the centre of our care.
So patients with the same name, we don't have anybody. Patients who are red will...
Handover now begins at the whiteboard with the safety brief. The nurse in charge shares essential information with all of the oncoming staff, identifying patients with high PEWs, safeguarding issues, those receiving IV fluids, those with infection control implications, and those with the same name. All staff now have a printed handover sheet with up-to-date details on every patient on the ward, and this is in S-bar format.
Hello, how are you?
Hello.
Hi, I'm Natalie. Hello. Hello, Katie. This is lovely Katie. Katie, this is Natalie. She's looking after you today. Hi, Katie.
Following the safety brief, nurses go to their designated area and introduce themselves to the patient and parent. Parents are actively encouraged to join in during the exchange of clinical information, and there is now an opportunity for everybody to ask questions, clarify and correct errors.
Have you any questions?
Yeah, Kitty was on a wee antibiotic to help with the rheumatology of her gut. I'm just wondering, is she on it again? Because I don't think I've given it.
We'll just have a wee check. She doesn't seem to be at the minute, but we'll ask the doctor about that.
Okay, that's great.
Yeah,
Thank you.
Yeah.
Parents are great triggers of information, which is very much welcomed at the end of a long shift. We then progress to the patient safety scan. This is key to the entire process, and it is an effective and efficient tool which identifies omissions which can be rectified immediately. Visualisation of the patient means that the oncoming nurse can now see what the outgoing nurse is describing. We revisit our PEWs charts, our fluid balance charts and our medicine cardex. We also check that our equipment is in working order and ready to use, and that the patient has a name band. As parents can see where we are, there are notably fewer interruptions, and should a child be in need of assistance, we are immediately available. Handover is now safe, efficient and timely.